Good morning. I was going to say
Evening.
good morning. Hello. I was on here at 8 o'clock. I felt like I haven't left all day. So good evening or afternoon, depending on where you're coming from. But yeah, yes. So I've been in this seat since 8 a.m. Actually 7:45 for a call. And you know what? What did Jim Carrey say? Good morning, good afternoon, good evening. So here we are. Welcome. Clifford, welcome. Jessica, welcome. Jim. And who's calling? 415 area code. Hello? Who's on the phone today?
How you doing?
So, Evan, I haven't been to the liquor store yet, but I am going to check out that tequila, Invictus, right?
But I got the name wrong.
What is it?
Be right back.
Oh, so he's teasing me now. All right, so we hit 95 yesterday afternoon. Today it got to, what did I send you, Barry? 93?
93.
Which is pretty good in the sun. It felt a little warmer.
And oh, see, you can't see it with my background. So I got to
Hold it in front of your shirt. Oh, okay.
Wait. Oh, is that how it works? No.
Yeah, go ahead.
It's okay. Choose.
Or just put your hand behind it the way we do when we're doing cosmetics YouTube videos like this. And then you can.
I'm just going to take it off for now. There we go. Oh, can you see that or no?
Can't read the label though.
No, I'm not there. Okay, good. Here we go. It's addictivo because it's addictive.
Ah.
See, it's empty. We emptied the top. This is where but it's a beautiful
All
bottle,
right.
and it's
All right.
amazing.
It's
All right.
wonderful.
And no, I don't have a cocktail. You just
You
reminded me I need a
Got
cocktail.
me hooked. You got me hooked. All right, Alan, welcome.
Good afternoon.
Good afternoon. And I apologize. I never got a chance to send that invitation to your friend.
Oh, it's okay. when it happens, it happens.
Yeah, well, you know what? The thing is, I've been working nonstop in the yard all weekend and then Father's Day and then so we'll get here. So, Jim, how you doing today?
I'm doing well.
Good.
Had
You
my 25-year-old show up unexpectedly yesterday on Father's Day from New York City. I live in
Oh.
Atlanta.
Oh, that's
Oh,
nice.
nice.
Oh, nice.
Yeah.
So,
it was
how did
good.
they get down? They drive, fly?
You know what she did? She had a friend of hers was driving down to Savannah. And so unbeknownst to me, her sister took a little 4-hour jaunt over to Savannah to pick her up and bring her back. And
Nice.
yeah, it worked out well.
That's
She's
nice.
going to stick around for a month or so, I think,
Oh,
until
great.
things start opening up in New York. So
Great. Yeah, I was just telling Barry, my son is in California, my oldest son, and he was supposed to ship out to Japan back in April.
Oh,
So everything's been delayed, and he has orders to report to Okinawa at the end of July. And he's like, Dad, I'll be home July 2nd. I'll be home for a few weeks, and then I'll start making my way to Japan. He called the other day and said, we can't leave California until they open up the state.
oh my gosh.
So he's
So
kind of
his-
frustrated.
His federal military job is locked down by a state government.
Correct.
Wow.
So every base is following the local guidelines for what the indication is. So it's, he's frustrated, but there's nothing, I told him to hang in there and we'll get it taken care of, but
Yeah.
very
Well, hey,
frustrated.
at least he's not stuck in Kansas. That's a.
Well, my middle son was in Kansas for a while and he had an interesting time, but
Don't say anything too disparaging. That's where I'm from.
I was going
I
to say,
figured
don't
that.
be knocking Kansas.
I didn't.
Are you from Kansas, Barry?
No, I have a very good friend who's from Lawrence.
Oh, from Lawrence. Yeah, that's nice there. That's a pretty town.
Mhm.
Yep. Good evening, Jessica. How you doing?
Splendid, thank you. Glad to
Excellent.
be back saying hi to everybody.
Excellent. It's like we never left. So
Seems like it was yesterday.
I know, it is kind of weird. So we'll wait another minute. I'm getting a couple emails. Some people are coming on and we'll
Sue
see.
Marie, I think, is coming on too. I had referred her to you guys.
Who is that?
Sue Marie Quenneville. She said
Okay.
she got the emails that she's on the mailing list, but she's somebody who works in marketing and has been looking for medical device marketing. I said, come and network.
I actually have a good friend who does medical device marketing. Here she is, Melissa. I got it, Barry. So we'll see. All right. Well, it's 7:05. We'll get going. Daylight. Well, it's going to stay light until 8:30, so we have plenty of time. But welcome, everyone. It's our first call of the summer. Welcome. So before we start, who's having warm weather in their neck of the woods? I talked to Catherine. She was stuck in the store in a storm, so she may be running late, or she texted me. But Clifford, how you doing weather-wise?
It's warm,
How warm?
mid 80s, lower 90s.
Yeah, that's not too bad. It's so funny. I was talking to someone earlier. I have a chair in my closet with clothes, right? So a few weeks ago, I had my fleece jacket there. I had shorts, long pants. In a matter of a week, I think we went through every season in New England. And I didn't put anything away because I thought I'd be wearing it again, because it does happen like that in May. So Evan knows that, right? Cold weather. So we'll see.
It's not, Long Island's not a problem with cold weather late, but this was a late spring from upstate New York, though. I remember in Albany, when I went to school there, we didn't have, the snow was on the ground up until May. Crazy.
Right. It was snowing in Colorado around Memorial Day, wasn't it? Like a few days before we had someone. So pretty weird. Uh-oh.
Man overboard.
Alan's going down with his phone. Hold on.
Cheers, I got a drink.
Cheers.
I
Excellent.
drank enough yesterday for Father's Day.
You know what?
Aw.
I don't think I drank anything yesterday, Evan. I was recovering from Saturday. I drank a lot on Saturday.
Well, I didn't drink any on Saturday.
I
That
know.
reminds me of I need a vacation from my vacation.
I know. So, all right, let's jump in. A lot of good things happening. Some things are pretty. Oh, here comes Catherine. Hopefully, she made it out of the storm okay.
What storm is there?
Well, Catherine's down in Baltimore. She said she got hit with a passing storm. So,
Yeah,
how was it?
it was like torrential rains, and you could hear the thunder and everything. It was all within about a mile of where the store was. So it finally let up just enough that I could make a run for it.
All right, we
Sounds
were
like
ready.
Tornado Alley.
Yeah, we were going to send a search party out for you, Catherine. Like man overboard. So
You need
All
some
right.
rain this way.
I know. So, so the interesting thing in Connecticut, we're going into the phase 2, and I got an email today. I wanted to share some of the highlights with everyone because it's interesting. When we talked about places opening, Barry shared some information this morning I found very disheartening about sales reps not being allowed to go into the operating room. And that prompted me to think about what's going to happen when we don't have access to the hospital, the operating room. So the title of this newsletter is Good News About Social Gatherings. Effective June 17th, and this is Connecticut, so I just want to throw it out to see where everyone is. Indoor private gatherings up to 25 people, outdoor gatherings up to 100 people, outdoor event venues, amphitheaters, racetracks, 25% of fire capacity and distancing. Effective July 3rd, indoor gatherings of 25, outdoor gatherings of 100 people, one-time exceptions for graduations of 150 people, which doesn't make sense because July 3rd, who's going to be graduating? But here's a big one. Outdoor organizational gatherings, i.e. fireworks, concerts, 15 feet of space, blanket to blanket, capacity of 500 people, event organizer responsible for compliance with guidance. So I asked, how come we can stay 6 feet away, but why do we have 15 feet away? Well, they want each party on the blanket to have 6 feet of space and then a 3-foot corridor for people to walk through.
That's going to look like nobody's attending the national fireworks.
I know. Well, it's exactly. So again, this is Connecticut, but when I got this, on one hand, I don't know if I told you guys this, but the governor was locking everything down and said, "Oh, don't worry, we'll open it." Well, his daughter is having an outdoor wedding in July.
There you go. That'll guarantee it.
So isn't it amazing? So here it is, effective mid-July, the date to be determined, indoor gatherings of 50 people, outdoor private gatherings, including graduations, 250 people. That's where the wedding comes in.
Yeah, right.
Outdoor organization. I think his wedding, his daughter's wedding, is the second or third week, and I bet you dollars to donuts 3 days before there's going to be a proclamation. So still 15 feet, but outdoor venues are going to go up to 50% of fire capacity. So it's very interesting how I was at Walmart, I was at Costco this weekend picking up stuff, and there's a billion people at the supermarket, Target, like every place in the mall was packed, and yet you're telling other businesses they can't open.
Right.
Very, very odd.
And nothing's based on science.
Right.
Because
Exactly.
they said maybe 2 people in the country have gotten it from outdoor that they can attribute it to, that it doesn't live on surfaces. And they say that the most prevalent problem is when people are speaking, it's through the mouth, right? You know, the droplets.
You have to catch droplets, that's it.
The super infector who was in, I don't know where he was in Massachusetts, but he was in a choir, and he was a super infector. And that's how they learned that that's the main transmission, is when people are opening their mouth and kind of like spitting.
Yeah.
Yeah, no, it's very funny. I shared an article from the New England Journal of Medicine, I think, with Catherine. Barry, did I send that to you too last week? There was an article a couple weeks ago from the New England Journal of Medicine talking about the efficacy of the mask and some of the things they found. And it's interesting, and it's a pretty well-respected article, right? So you got to give it some credence. So I'm going to share it with you just to get your thoughts on it. It's one of these things that the name of the article, Universal Masking in Hospitals in the COVID-19 Era. So just something to consider. All right, so Barry, what are your thoughts on sales reps going into the hospital?
I was just thinking that, excuse me, that's generally how we kind of keep our eyes and ears on the competitors, because a lot of, or even complementary things, I always would run into other reps either in the parking lot, or because I didn't work in hospitals, but I have the feeling that it's going to be a lot harder to get that intel from the feet on the ground, because so many people are going to be limited to where they can go. And because of the distancing and the spacing and the number of people, they're probably only going to allow one rep at a time wherever. There's not going to be a group of 2 or 3. So the chances of you running into them in the hallway or in those places where we normally do, they're just not going to be there. So I'm curious to find out if this really has an effect on networking, where we normally wouldn't do that, to kind of keep that eye on our competitors. But I think this is a case of keep your friends close and your enemies closer. I have the feeling that there's going to be a little bit more camaraderie or give and take electronically or with phone calls, because we're not going to have that face-to-face of hanging around having a cup of coffee waiting for the doctor to come out of surgery. It's just not going to happen. That's my personal opinion, not based on anything other than that.
All right. Anyone have any thoughts? I mean, I know some hospitals were trying to cut back with the sales reps, but I know the highly technical and intensive equipment cases, they're going to need surgical support. There's no way that you're going to keep all the reps out. I mean, they've been talking about that for a long time. This might be a way to do that. I just don't know if the hospitals are up to that.
Yeah.
It'll be the same, that some people will listen to it and they will fail. But a rep is worth their weight in gold by the relationships that they have and how to support, be a resource to their customer. So we all of us are that way. I remember talking to the director of perioperative services about these rules when they made them. I said, how can you kick reps out? She says, I'm not talking about you. I'm talking, and she points. That guy, he gets on my nerves. He comes in, and then she gave me an education about, because I was new to sales at the time, about a no charge PO and how it's protecting me as well as the hospital. And it was being a resource to your hospital when if they're going to share that kind of thing to you, it would open my eyes and go, oh, I didn't even know I needed a no charge PO for my product at the time. So I think it's all about building those relationships and being there for your customer. They're going to find a way to get you in.
Right.
Yeah.
That's awesome.
Anyone else have any thoughts? What changes on the horizon?
I
Hospitals?
hope that it doesn't last like this forever, because it's important. The relationship is important and the face-to-face is. But I see, I get what Barry's saying too, but we got to hold on to hope and be optimistic.
Well, I was
sorry, go ahead.
sorry.
No, go ahead.
I believe that the people who are doing it right will continue to do it right. And as I just sent Evan a message. I said, no one is above the law, but some of us go around it. So even if we aren't allowed, people will find a way, but I still believe that I have the feeling that we have fundamentally changed the way we are going to be dealing with doctors' offices and hospitals. And I think the world for a pretty long time, until there's a vaccine, the social distancing, the limiting the number of people, that is all going to come into play, but we should do it smartly and make sure that, as you said earlier, Steve and Evan, that it's based on science. Right now, people, they're just, throwing the hammer down to try and make sure everything is safe. And it reminds me of an expression that Steve told me once a long time ago, and it has stuck with me ever since. We usually use it for other things, but the expression is, it's like trying to carve a machine gun, trying to carve a turkey with a machine gun. You just obliterate everything. And having these extra strict, 15 feet apart, the blanket's not touching, nobody, that stuff, it's taking it to the extreme. And I think it's going to go and then work its way back into something that's manageable. But I think we all do need to realize that there are going to be some people who are those box checkers and rule followers, and they're going to measure the distance, and we will have to deal with those people, but we're also still going to have our relationships that we can count on to get that extra information. And I am, for one, am so thankful that we all got on board with networking when we did way back when, because the people who are just figuring it out now are so screwed. They're so far behind. I mean, do you see people on LinkedIn that have 75 connections? You're like, what rock are you under? That's the only way we're going to be able to communicate with people. We can't just hop on a plane now and fly somewhere. It's all going to be electronic, and it's all going to be based on relationships. It's still the number one way to keep things moving forward, even if you can't do it face to face. And that's my soapbox for the evening.
Very good.
Hey, Barry, remember you said you had nothing to say tonight? Barry's like, yeah, I got nothing to say tonight. I'll just come and listen.
Yeah, that was your forewarning. You should have known that, Steve.
I did. You notice I was muted, so.
But you know, what Barry's saying is interesting because, as you know, I'm not a rep myself, but I just think about, you know, the medical device reps that need to be in surgery, you know, how, if that's going to be precluded from happening, what happens there?
It won't.
It's not. It's just, they're just going to limit the number of people. What I mentioned earlier was my guess on this subject is going to be that there's not always going to be able to be like multi-specialty teams in the OR. They're going to have to pick like, you know, the two most important people and let those two people in. It's not going to be like a giant group with a meeting outside in the hallway waiting to be had after the surgery is over. That
right. Well, so here's the thing, and Evan knows this, and Cliff, you guys, you know, who've been in the OR, there was a couple of surgeons I worked with in sports medicine. This guy would call in 2 or 3 reps because he always wanted to have his options open. And we would be, I mean, we actually were all scrubbed up, or we had scrubs on, and we were in the central core waiting for all of us to go in, depending on what he used. And it got to the point where you're like, boy, this is crazy. Other places would say, just stay here in the doctor's lounge, and if we need you, we'll call you in. So we're like, okay, but if we're there, we can prevent things from happening. By the time you call us in, the damage is already done. So that doesn't help. So some of the hospitals have stricter policies, to Evan's point. Other hospitals, they want you there, you know, before the room's even ready, so they feel secure, because some of the nursing staff, they're overwhelmed. And if, again, you have a highly technical product, you need to be there to help the nursing staff get ready. That way, the nurses don't get yelled at and the doctors don't yell at people. You know, it's really keeping everyone happy beforehand.
Right.
So, but to Barry's point, you know, what's going to happen when, so Yale University, Yale New Haven Hospital, it's one of the biggest hospitals in my area, right?
Mm-hmm.
But, you know, they have 30 rooms. And you think about if you had 30 surgeries going on and only half the rooms have sales representatives, that's a lot of people in that room. And there are times when they did, right? They had all these cases going on. Plus they had an outpatient surgery center. So, but this is what I've told people who aren't in the medical device world. Biomed repair, there's anesthesia people there all the time. There's people fixing the lights, people fixing the beds. There's not just, there's a lot of service people in the hospital, vendors doing work. We're no different. And when they think that, they're like, oh, okay, that makes sense. So we're just there helping, just like every other person. The guy who fixes the copier in the president's office, is he any different than us going in and doing our job in the operating room? Probably not. But, you know, he has to go in there and get the copier fixed. So what was that, Jim?
I said, I think that's a little bit of a stretch, Steve, but I'll take it, you know.
But it's still another person in the hospital who's already been in multiple hospitals.
Right.
Yeah.
It's that whole essential worker thing. Like the people are just going to have to be much more judicious about deciding who's essential and who's not. So there are going to be medical devices where somebody always has to come with it, or better safe than sorry. But I think you're not going to see all the reps in at one time. It's just going to be like when you're shopping and they have curbside pickup. You have to schedule an appointment and you can be in the hospital from A to B.
All right. So
I'm sorry, you were mentioning like there were 3 reps waiting for the surgeon, right, to make a decision. Those days, I think, because when I think about the conversations that I had, and I'm talking maybe 10 years ago with Phyllis McCready, who was, she was the CEO, what they call Chief Procurement Officer for the Northwell. And she's like, I don't care about how good you think your product is. And she used examples of like spine implants. She says, I want independent research done by my institution. And then I'm going to decide, it could be you, that yours is the best product. And then I'm going to get rid of everybody else. And we're going to have this great relationship. I think that what we have to be aware of is that I think this is a great opportunity for the Phyllis McCready's of the world they've already done it since it's already 3 or 4 months. That's what I would be doing, because the standardization is a huge thing in these IDNs right now to try to control costs. You reduce the number of SKUs, and they're not going to allow the 3 reps there. They're going to want the best product, and they're going to tell the surgeon, you got to pick one. I think that's what's going to happen.
And you can do that with certain things, Evan, but and again, believe me, it made no sense for us to stand there. But when you're a smaller level 2, level 3 community hospital, and your doctors doing elective surgery, bringing in the money, you're going to bend over backwards because this guy can take his business to the other hospital on the other side and say, hey, we'll accommodate you here. So you run into all these nuances. The level 1 hospitals, the joint centers, the spine centers, yes, you can do that. But here's the funny part. You always run into this. Well, you have 2 competing champions. Company, I use Windows and this guy's using Macs. And they're both experts in their field. And you know what? They always carved out exceptions for people. What are you going to do? This guy's a player. This guy's a player. So, they
try. I think
right.
that this is what's happening and we have to fight. And so do the doctors. We had to fight with plenty of surgeons to go up against Phyllis McCready when she wanted to go with the cheaper product, because I don't know what the difference is. Meanwhile, the doctor had to go in there and say, look at what just happened. This patient had, an open domain that failed because we used an inferior product. And it's going to cost you more money. Like, we need doctors. We have to be the resources for those doctors and provide that information. But we're going to have more. I'm not in it anymore. But medical device industry is going to have a lot more fighting to do, where they're going to have to really know how to position themselves and win with value, because they're going to put the foot down. Regardless, I mean, look at what's going on in society right now. It's like Earth 2.0. Doesn't make any sense. It's not common sense. It's craziness that's going on.
But you know what? You have organizations, and I'm going to pick on HCA. About 6 months to 9 months ago, I was in HCA, and HCA corporate had required a switch to one of our products. The doctors flew a hissy, and it did not work because the doctors blew that big of hissy. The doctors still have a ton of power. You're not going, even in an organization as large as HCA.
Okay. I see they have less and less, but it would have been getting the clinical buy-in is more important when you're going to bring in a new product. You got to get the clinical champions in order to get it to come in. If that was your product, that would be, to me, I
came in the middle of it, and it was
right. So you didn't have, but that was the flaw, is that the person before you didn't do it. We've done the same thing. Somebody, and then you got 10 years of bad blood because the doctors are like, yeah, I get it. It's not the way to do it.
But corporate HCA has pushed down a lot of things, and the local HCA hospitals haven't accepted them because of lack of doctor buy-in. And you're talking a huge organization. The same thing I know has happened at Dignity's, even at Sutter's and Kaiser's in Northern California.
Yeah, Kaiser's a challenge.
I'm going to ask a question. Who still wants to work in the medical device field? Or healthcare? I mean, it's so funny, Clifford, and you bring up great points. I mean, we talked about this 20 years ago, 15 years ago, and it was always, we're gonna consolidate, we're gonna save money, and the pendulum would swing.
And it always does.
Right, and the so-called savings never materialized. Right, you're not gonna the amount of savings they thought they would get wasn't really there sometimes, because you know what, the surgeons could pick up. Most of the places I worked, especially in New Haven, Hartford, Springfield, there were always competing hospitals. And guess what? These guys could just take their practice and go across town, and their patients, they were fine. So I agree. There's a balance there But I also understand there are a lot of, what did we call them, Barry? Lounge lizards hanging around, you know?
Flies.
Oh, barflies?
The ones that sit at the front desk.
Yeah, yeah. I mean, we were there. I mean, I really enjoyed my job because I was able to get into the back door. They let me in. I was there consulting, right? Dr. So-and-so needs you. We need to plan out the surgery. It was different. We weren't selling. We were servicing. We were consulting. So when you have that relationship to go from a vendor to a strategic partner, it made a difference. And, but I think a lot of organizations are positioning themselves, and it's like that. And it certainly makes, I don't know, is this the normal evolution other than COVID-19? Possibly.
I think it is.
Yeah.
And I will also say it this way, because I've been in a lot of organizations that don't believe in GPOs. And you've seen the swing from everybody has to be on the GPOs to everybody can't be on the GPOs to everybody has to be on the GPOs. And you think about the power of the GPO and how it's gone back and forth over the last 2+ decades.
So, Jessica, how are you doing? I haven't heard much from you tonight.
I think she just answered her phone.
Oh, was that Jessica's phone?
Yeah.
No.
I still think, though, that, and I still keep going back to this, you know, salespeople, we always talk about positioning yourself as a trusted advisor. And that's a combination of product knowledge, excellent customer service, and relationship building. And I think new reps who haven't gotten the hang of it yet are probably going to have a really hard time. And I think this is going to be an opportunity for seasoned reps who are good at relationship building, you know, the good salespeople. Those are the people that are going to thrive. The ones that take shortcuts and, you know, they don't know their product and they try to BS their way through a meeting. Those are the ones that the doctors are going to weed out. And some people will sell anything. And if it's an inferior product, they're just not going to be able to get in, because not only does the product have not such a great reputation, if they have somebody green representing them who can't hit that bar, it's going to go downhill. So I still think it's going to be people dependent, hospital dependent, product dependent, and nobody has a crystal ball. I mean, we could all be completely off base, and 6 months from now, we're going to be like, oh, can you believe we used to think XYZ?
Maybe we'll be selling alcohol.
What we do know, the trend has been going towards consolidation.
Mm-hmm.
That in the last 20 years, there's so many more IDNs and less independent hospitals. And in the next 5 years, they say that 50% of all hospitals will be part of 300 IDNs. And so it begs to look at that we need to figure out how can we prove to our customers that this standardization or using protocols and critical pathways and reducing the number of SKUs based on what they're using, right, will help them not only improve their bottom line, but it'll improve outcomes. Because part of the problem is doctors practice medicine. One doctor will go in and do one thing one way, and they have residents in teaching hospitals, and then another doctor will go in and do it completely differently. And it doesn't mean that either one's wrong, they're necessary. But if there's no standardization, what ends up happening is you can't measure it. How do you measure the better outcome? You know, there has to be a way for them to do this in medicine. And that, I remember going to a presentation by a surgeon for Northwell when I first started at one of these companies as a manager, and there was a doctor talking about doing this for the OR. And now they have a standardized, what's it called, central sterile for all of Northwell in Bethpage, which to me is like, the concept is mind-boggling, because every surgeon, I mean, that's their bread and butter. It's like, I have my, you know, tray, and my tray has what I want on it, and they know what I want. Well, that's going away. Maybe not completely, right? I know that. Wow.
I was just going to mention, though, because we got onto this topic, I have the feeling, and this goes back to when everything started reopening with non-emergent surgeries that were considered elective because they were non-emergency. And if you've been watching what's been happening from a geographic standpoint, the big boom and the big push for like the last, I want to say 12 years has been ASCs. And I think we're going to continue to see that because that is how those doctors are going to be able to keep their tray the way they want it. A lot of doctors go in together and go in as a group and build an ASC, and they do that specifically because they can work around the things they don't like about being in a hospital. And I think what's going to happen is we're going to see ASCs for everything non-emergent, and hospitals are going to go back to being for, you know, the emergencies and the big surgery.
That's already happened. I mean, we were selling a product that was a surgical cover dressing, and we saw a decline in the hospitals of 8%. Well, this was 2-3 years ago. Well, guess where it went? It went to all the ACSs, but the management leadership didn't figure it out. Like, look what they're doing. They're putting, and then there was an international meeting for total hips and total knees for orthopedics. And then there's now a mandate from CMS I think it was maybe last year or the year before. It is no longer standard to keep a patient in the hospital overnight for a total knee. So it was fascinating sitting there and listening to all these surgeons kind of best practice and talk about, well, what does that mean? If you're not having a patient overnight, you've got to consider, well, what kind of anticoagulation were you using? Because a patient could bleed, right? And what kind of anesthesia were you using? Like, all their practices had to change. It was fascinating. And they were all scrambling because they'd all have to write letters, letters of medical necessity, which you're not guaranteed, but they just would totally screw them up. But they found also patients liked the ACS going home was a 58% improvement in satisfaction for patients. So it wasn't like they were just saving money, right? So the patients liked it and they had to conform. They weren't happy about it. They were making less money. All these, I think, and now that I've been out now for, 6 months, but I mean, I think things are going to be happening even faster now.
You think about
the industry,
cath labs and the outpatient IRs, the ones that are in ambulatory surgery centers. I think that's going to become more. We talk about the pendulum swinging back and forth. There was a phase where there were a lot of those built, and then they quit building them. My guess is we're going back to the phase where there are going to be a bunch of them built.
There's a lot of them out there.
Well, I can share this with you too, and you might have read some of this. You know, when the elective surgeries were canceled, many hospitals around the country were starting to lose money because they stay afloat, solvent, by making money with the elective surgery to run the the emergency rooms and to do some of the other things that they do. So it's hard to have one service without the other. So you can have all the outpatient surgeries going to the off-site, but the hospitals will not be able to provide the level of service. And then we run the risk when you need catheterization and ICU units and all that, how are they going to function? Or do we need to change the pricing model with some of that? And again, bigger questions to ask, but the pendulum has swung back and forth for a long time. And everyone, for years, hey, we make money by keeping people in the hospital. There was no really medical reason, but we kept them there. Most people could go home with a nurse coming home to take care of them, and it would be cheaper. But was it convenience for the physician to make rounds? Possibly. So there's a lot of things when you start peeling back. I don't know if there's a one size fits all, but I don't know. The question is, how will it affect each of us, right? Whether you're selling into the hospital, surgery clinic, providing services to healthcare, It's going to be interesting. Now, hopefully, I don't think it's going to change in the next few months anytime soon, but this might be, are we heading in a new direction? I don't know. Other thoughts? Anyone have a good question, topic? Anyone have a good interview?
You guys are using a lot of acronyms I'm not familiar with, so I don't know if I should just hang up and leave or just
No.
look stupid. But
ASC stands for Ambulatory Surgical Center.
okay.
Evan, if you want to share what GPO and IDN stands for, that might be helpful.
Oh, Barry got them all down.
Okay,
You know
so
what? Beauty
Group
and
Purchasing
brains.
Organization is the
Pardon me?
GPO. Group Purchasing Organization.
Okay.
It was
Yeah.
just a buying power.
Yeah.
They all go through this one GPO and they can get better buying power. And it's price driven based on usage.
Right.
IDN is Independent Delivery Network, which is like Kaiser, Sutter, an
Yeah.
owner of multiple hospitals.
Yeah. The consolidation. Because, it's interesting. I was reading a white paper today, and it's not one that's, the deepest kind of white paper. It's written by somebody that does essentially is a executive placement person for people in the arena of functional medicine. And so, they're making some pretty bold predictions, literally like the pharmaceutical industry is going to die in a year. And I don't quite believe that's going to happen. But one thing they did bring up, and it was, it's according to the 2018 Edelman Trust Barometer. It was reported at the World Economic Forum in Davos. And it says that trust in the U.S. healthcare system fell by 20% or 20 percentage points from 2017 to 2018, from 75% to 55%. Edelman termed that drop a crash in confidence in U.S. healthcare. And so, it's interesting. I thought of that particular quote in there when you were talking about the pendulum swinging back and forth. So it led me to thinking, what causes that pendulum to swing back and forth? And so I really pose it as a question to all of you. Is it, where's the final decision maker? Is it, the consolidating organizations, or is it actually the consuming public?
And you're really opening a can of worms now, Jim.
That's a great question.
I'll add one other place that makes it more of a can of worms: federal government. Local governments.
Well, why do you think why it went down? Why do you think it went down so much?
Are you asking?
Satisfaction.
Pardon me? The
Why
satisfaction?
do you think patient satisfaction went down 25%?
I mean, I have my own biased opinion, and if you want, I can share that with you. But
What did it say in the article?
no, I didn't. I'll have to go revisit. It's a 20-page white paper, and I just happened to pick that particular one out. But and I don't know that they went in depth. As a matter of fact, I think those are some weaknesses of this particular. The thing is, you read some of these things, 20 pages, you pull out one nugget that might be good, and some of the rest you just have to discount. But I do think that, we are seeing a greater numbers of people are looking towards a broader context of how they can get better. And the medical industry is doing the best it can, using strictly allopathic medicine and allopathic methods to address issues. But I think that the consuming public is shifting. And in my estimation, the best thing that could happen is if the medical industry would make a bit of a shift along with the consuming public that then integrates other protocols and broadens the role of the average physician. And particularly like in what you're doing, Evan, we need to see more of that. And I think that, let's face it, you always are going to have surgery. You're always going to have so many of those very important allopathic protocols. But I do think we're really in the midst of a bit of a paradigm shift.
And I think one of the things that got brought up earlier, I think a lot of the dissatisfaction from the consuming public, i.e. the patients, is those people that go into the hospital for something major and feel like they've been thrown out as soon as their anesthesia wears off and they've peed. Like, oh, you can't go home until you pee. And then they like flood you with water so you'll pee so you can go home. I mean, there are steps in the protocols of hospitals that are changing that have a profound effect on the patient's perception of how they've been treated. And you have stressed out nurses. I mean, some of these TV shows that highlight all the bad stuff about medicine, and then the doctors all complain, well, that TV show is giving us a bad name. They only show the bad stuff. If there was no bad stuff, there'd be no show. So it's coming from somewhere. They're not making it up,
Yeah.
right?
Well, and on 60 Minutes last night, even though this was about drugs and the opioid crisis, but they interviewed one of the guys who had been like a whistleblower,
Yeah.
and he was talking about how the drug company set it up. They did their training and everything. They monitored how many times a doctor would order and how large the order was. That was the goal, which, I mean, we're in sales, we're all supposed to sell, but they would do it by giving away, trips to strip joints. They would have speaking engagements that the doctor would be able to go on and get a high fee for doing that. And if that doctor's writing prescriptions fell, then within 24 hours, the rep was supposed to be out there saying either you go back to writing the number of scripts and having it be dosage amounts that are high, or the gravy train is going to be, not coming to your door anymore.
I hope you're referring to the worst of the medical,
Well, no, but
a small percent.
I'm talking about 60 Minutes, giving that information out to everybody, and the opioid crisis, which so many people are touched, have someone like that. So that kind of information. And I listened to it knowing I have a friend who sold drugs for a major company, and she was not the kind of person at all who would compromise her integrity. So I didn't know how much of this on 60 Minutes was valid, but I just was going to say, here's another reason why people might be losing faith in the medical, the medical industry and what they encounter. Kevin?
The main reason why I think there was such a drastic change in people's perception of the value they're getting is because of the changes in healthcare from the Affordable Care Act that was put into place around 2015. I think it was 14, 15, but it's been over several years, last 7 years, maybe it's 2012 or 13.
I think it was more 12 or 13, I think.
Right, but the impact, because it was done gradually, major impact didn't happen until 15, 16. And then there was that change when we changed, presidents, and now things had changed. But there were so many people that, and including myself, who I don't feel like I even have insurance. But the problem is not the insurance and it's not the healthcare. It's the problem of the way it's set up. CMS for the last 25, 30 years has said it's not sustainable the way that we have healthcare. It's not sustainable and we're not going to allow it. And that's why back in the early 2000s, they decided to completely reform healthcare. And that's why Obamacare or Affordable Care Act was started. But it has nothing to do with the administration. It's CMS. Mm-hmm. And I mean, I did a lot of research and work with hospitals on what's called DSRIPs. In a nutshell, the government had billions and billions of dollars that they were giving to hospitals to say, if you transform the way you deliver healthcare, we're going to give you billions of dollars. I mean, it was $80 billion that they had, and it was, I think, $8 billion just in New York State alone. And I have hospitals like SUNY Stony Brook, Nassau County Community Hospital. They got $300 million, $600 million from the government. Why? Because it's kind of like if you had a budget, let's say you were spending $100,000 and all of a sudden they said, you only get $50,000. Can you live the same lifestyle? You're not. So that's what they were doing in healthcare, saying we're going to be cutting healthcare reimbursement by 50%. And the hospitals kept fighting, but they said, it's inevitable. You're going to have to change. So we're still going through this reform. And the biggest problem right now is, and I think this is what needs to happen, is the fee for service has to go to pay for performance. It will make such a huge difference. I saw the difference. They finally flipped the switch in last October in the nursing homes.
How do you define that, pay for performance?
So I'll give you an example. So when you go into a nurse, because this was just happened to be with my father-in-law, when you go into a nursing home, you get paid number of visits you go to physical therapy, the number of visits the nurses have to see you, because there's not as many nurses in a nursing home. No, it's called nursing homes. Right. So, you were getting, the nursing home was getting paid on the number of times they saw the patient, not on the outcome.
Yeah. Okay.
So it's the same in wound care centers. It's the same in the hospitals. You go to a hospital and they want to, I remember going, when I was working in the hospital, we need to get these patients in here so we can get them tested as much as we possibly can. And there was no communication from one hospital visit to another, from one doctor to another. So so that all of this has been changing. NYU has an integration now. Northwell has an integration. Mount Sinai does. New York Presby. They're all working on this, but it's still not perfected. There's still no fee pay for performance. That is going to transform our healthcare. What does that mean? It means that you're not going to get paid if the patient doesn't see the results that they're supposed to see. Now, 80% of patients should follow into that pathway. The other 20% are outliers, so doctors are not going to get screwed, because there's always those patients, you go and say, hey, your blood sugars, are out of control and your A1C is 13. Don't you think you might want to, take better care of yourself? And the patient doesn't. That's the patient's fault.
Well, it is, but the patient doesn't have to pay for it under this system. Now, I don't know if you've read Make America Healthy Again by, what is their name? Do you know who I'm talking about? Sapphire.
That's the older book? That's an older book?
No, this is absolutely brand new. Okay. Make America Healthy Again by Nicole Sapphire. And in that, she's really proposing that insurance absolutely be reflective of a person's decision on their own lifestyle. And if
you try and do that with the way society is going right now, where it's victim society, I'm a victim, instead of saying I'm going to take responsibility.
But you know what you have as an offshoot to that? What you have are.
Well, I was going to say, we're supposed to be talking about sales and medical device and business, right?
Yeah. And Alan raised his hand and he's been waiting patiently.
All right, go ahead, Alan.
What I was going to refer back to is a 60 Minutes point of view. It was a good article. Unfortunately, I disagreed with the main guy when he says the only way to be successful in that business was to be unpassionate. And I was in that situation with an opioid as well. I spoke with a doctor this morning for a breakfast event, and he said that was an outlier pharmaceutical company, meaning they didn't necessarily follow the unwritten rules or guidelines of pharmaceuticals. And the guy who owned the lollipop, so to speak, of fentanyl, they were trying to promote it not just for cancer, which was for the end stages of cancer. They were trying to do it for osteoarthritis, rheumatoid arthritis, on and on and on. So it was really a good article. They spent a year doing it. Unfortunately, it wasn't your traditional pharmaceutical company, but the point of their being is that people were paid. They were looking for the right doctors. They were looking for doctors that could be bought, and a majority of those doctors cannot be bought. So it was just, I respected what they were doing. I saw what they were doing, what they were trying to say, but I have to personally say is those were people who maybe did not care as much for the patient's benefit as the bottom line dollar. But everyone here, I've been listening so intently. There's so many great thoughts about what's going on. And I think that we're not going to know the end result for months down the road, like Barry was saying. I do believe that something is going to come out of it, and I think it's going to find its own path.
Alan, thank you. You really gave a good synopsis of what it was, the clear picture of what I was trying to say. And my point that I wanted to make was it's programs like that where people get disenchanted because they hear about the doctors being able to be bribed, if you will, and they're not being clear on saying this is an outlier, this
Yeah.
is a no-name company, these are sales reps that wouldn't be able to be hired and work for a reputable organization. None of that goes through their head, because we were talking about the question of why is this swinging on the pendulum back and forth of patient satisfaction. And I was just mentioning it's programs like this, because there isn't critical thinking applied to that when a lot of people are watching something like that. So I really appreciate you clarifying things on it.
Well, I only clarified it from my point of view. The sad part was the guy was a billionaire, very wealthy. The places that they were eating were his own restaurants that he owned.
Yeah,
So he,
yeah.
he was able to bend the rules, as I call it. I don't break rules, but I do tend to bend them the way I can and legally get away with it. But it was, again, the pharmaceutical industry has been under scrutiny for many, many years. I think the healthcare has been under scrutiny for many years as well, for that point of view.
Well, and I also know when I called on surgeons, there's not one of them that I could think of that didn't. I mean, to me, I couldn't imagine them getting into the kind of cahoots, if you will, that was outlined on the 60-minute thing. They just didn't strike me as that caliber or not caliber of person.
Well, it's the Hippocratic Oath, first do no harm. If they're putting their profits and their relationships with the drug companies for what they can get out of it ahead of their patient outcomes, there's something seriously wrong with that doctor.
Well,
Yeah.
I know. But again, the only reason I brought it up is because people watching that who don't have the inside information we do, they're going to take away a message that doctors can be bribed and are only in it for themselves. And my personal experience working in a clinic when I was in my late teens, and then also with all the doctors I've called on and worked with, it's like, no, I don't think there's a bad apple in every industry or whatever, but they aren't bribable like that.
Yeah, and that's what I was trying to get across. I knew two doctors that may have done something similar, but they would not have outwardly prescribed the wrong medication, or as they said, a significantly higher milligram of fentanyl, knowing that the outcome would have been an addiction. I don't know. Like I said, I know probably 50 doctors, maybe one or two would have done something like that, but as soon as they saw the ramifications, they would have stopped. So I'm not so sure I'm clear on what the guy was doing, but there's a little question mark in my mind where the truth completely was.
Yeah.
There's always three sides to a story. Your side,
Absolutely.
my side, and the
And the
absolute
truth.
So it's interesting where our conversation has gone. This is actually a very interesting conversation. I don't think we solved anything, but we certainly discussed the heck out of it. That's for sure. Anyone have any news or information or anything they want to bounce out to the group before we wrap it up? Yep, just proves there's a lot of work for us to do before we move on. So, all right. Well, thank you everyone for joining us. Have a great week. Stay cool, be safe. And if you're around Thursday morning, stop in and say hi.
Thank you again.
Thank you.
Thanks, everybody.
Thank you guys.
Bye.
Yeah.
Have a good night.
Hey, and Barry,
Yes.
your lipstick looks fabulous.
Yes, all people who think it looks fabulous say aye.
Hi.
Aye.
Bye.
No, I'm just jealous.
Nice to be able to put it on. I've been wearing a mask.
Some lipstick.
Yeah, exactly. Is
What
it
do I-
mask proof?
Right, I brush my teeth and shave once in a while, right? It's like,
You
Where's
don't
your
even do a good job shaving. You didn't get your whole face.
that's true.
Where's your lipstick?
Right here. It's called Chapstick Spearmint Classic.
There you
Okay,
go.
it's hidden by your mustache. Sorry about
Yeah.
that.
So it is pretty funny. But yes, I'm very envious. Every time Barry gets on here, she upstages me. I'm like, forget it. This is the last time. No more for Barry. So, all right. Have a good night, everyone. We'll see you
Good
on
night.
Thursday.
Thank you.
Bye.
Bye.
Bye bye.